one by one.
Really scary. Right, does it matter?
Yeah, come on in, folks.
Okay.
Well, it's not quite Wembley, is it? But and I always find myself competing with Victor for stage presence, and I lose every time. So I really appreciate you coming today. We've got a really interesting 25 minutes. We'll make it pacey, and I hope we'll give you some great food for thought. And St John Ambulance have a stand, so you can come and chat to us afterwards. I'll introduce my fabulous panel. Really grateful for friends of St John, people that we've worked with and know well, coming to give their insight into this very important issue. Caroline, tell us a bit about you and what you do in Age UK.
Yeah, this is like a talk show,
Isn't
this weird? Hi, I'm Caroline Abrahams. I'm the charity director at Age UK and one of the co-chairs of the Care and Sport Alliance. And great to be here because this is such a big issue for older people.
Fantastic, thanks, Caroline. Emma.
Hi everyone, I'm Emma Easton and I work for NHS England, and our team lead on voluntary sector partnerships and trying to increase the quality and number of people who are volunteering in England.
Fantastic, thank you. Jason.
And I'm Jason Killens. I'm the Chief Executive for the Welsh Ambulance Service in Wales, obviously. And there we operate all of 999, all of 111, and all of the non-emergency transport stuff too across the country.
Brilliant, thank you. St John Ambulance has been on quite a journey in recent years. Of course, we had the honour of working with so many of you in the pandemic, particularly around the 26,000 volunteer vaccinators that went out across the country, vaccinated over a third of the nation. And in that, we demonstrated what St John can do to work with colleagues in the NHS to make a difference in communities. And our conclusion from that work, the legacy, if you like, is an understanding that we believe that community first aid in all of its forms can make a difference. It can save lives. But we have been considering, where do we put our energies next? We will continue to do our traditional work of first aid in communities, at events where people love to see us, and of course we love to be there, whether it's football, rugby, or in my case, Kylie Minogue. We are keen to continue our fantastic ambulance service, the ambulance auxiliary that works with NHS ambulance trusts across the country. But we believe there's something more important that we could do that could really make a difference. We've looked at where the greatest impact first aid could have in communities, and we believe that impact is in falls. We've determined that really we want to be on the side of fallers. We want to take the side of fallers, because when you think about it, when a faller falls in their home on their own, that's an emergency for them. It's an emergency for their family who are dislocated from them, who can't get to them in time. For the community, when an ambulance arrives, it appears that an emergency is happening. And yet, we're not treating falls as a community health emergency. We are not responding as a system, we're not responding as a nation, we're not responding as communities as if this is an emergency. And we know that there are real challenges for those people who are falling, and there are really negative outcomes as a result of our failure as a community, as a society, as a system to get this right. And one of the reasons I've asked Caroline to come is because, Age is working with the frail communities perhaps more than any other organisation outside of the NHS. And I just wondered, Caroline, in terms of your perspective of the people who are falling, what's happening for them?
Yeah, well, there are a lot of them. That's exactly as you said. It's such a common occurrence, isn't it? And of course, falls mean very different things to different people depending on the severity. And I'm speaking as someone whose mum had a catastrophic fall and lost all her mental capacity, was in emergency care, etc., etc. And I was there. So, you don't have to tell me about very serious falls. But I think, and obviously for people like my mum, it was absolutely the right thing for her to go to hospital and as quickly as possible. But that's not true for everybody, is it? That's such a wide spectrum. And lots of people who tumble or stumble or slip. And I suppose for those people, there are a number of issues. Firstly, what's actually going on for them behind the scenes? Why have they fallen? Could it have been prevented? How do we stop them falling again? How do we make sure they're safe on the day and make a good recovery? But really, it's a trigger event as much as anything. And I think from that point of view, that's why it's really important that this isn't just seen as a sort of statutory clinical issue, but is also, as Martin says, and as St John's Ambulance are doing, seeing the benefits of having the community sector really well involved in what happens. Because obviously, you know, ambulances are busy people, they've got lots to do, but actually really big role, I think, for the voluntary sector in just finding out what else is going on and doing all the other work, signposting people to extra support. And certainly some of our local AGKs are already doing that, and I'd like to hope there'll be more of that in the years to come.
Fantastic, thank you. Jason, I mean, we've been saying it's an emergency, but for the majority of ambulance services and the majority of falls, this is not going to be categorised as a Category 1 or a Category 2 call. So the response is inevitably going to take longer. And we know that for many ambulance services, the average response time is 6, 7, 8 hours or longer. And yet the NICE clinical guidance on people being on the floor for over 4 hours indicates that that's problematic. How is it for the ambulance service? What are you seeing from an ambulance service perspective?
Well, that's right, Martin. I mean, so just about 1 in 10 of our 999 calls in Wales relate to fallers, and that will be a picture which is replicated across trusts in England and the rest of the UK too. And you're right, you know, often, certainly non-injured fallers will be categorised through the 999 system as a low priority. They will wait much longer, but of course we do know that those patients on the floor will inevitably come to avoidable harm as a result of those long waits. And that's one of the reasons why in Wales back in 2018 we developed a falls framework and a falls service responding to those non-injured fallers in partnership with St John in Wales, because we recognised that those types of 999 calls were waiting far too long and coming to harm. And we would never be able to prioritise them and respond in a quicker time period, given the pressure across the rest of the system. So, in the last 4 or 5 years, that service has developed well. We were seeing, in 2018, about 3/4 of all of those fallers' calls getting an emergency response, albeit in hours, as you were saying, not minutes. Last year, that was down to about half, so we've made some improvements, but there's much further to go.
So what's the difference between a commissioned service that delivers that kind of bespoke falls response and an ambulance responding? What are the kind of time differences that we're talking about?
Well, so the commissioned service in partnership with St John, we've got a couple of levels in that, a level 1 and a level 2 service. The level 1 service does respond to non-injured fallers and will see a response in 20, 30, 40 minutes, hours quicker than we would see an emergency ambulance responding. Yeah. And of course, this is a tailored service, particularly for that type of patient, that service user. Yeah. So they get a quicker, better targeted response. They're off the floor much more quickly. There are other elements of assessment which can also be undertaken by those trained St John operatives on our behalf. So we see very good results in terms of patient satisfaction and much quicker response, and of course a reduction in avoidable harm.
Yeah, and I've seen your research, which I think is excellent. In particular, I was struck by the lack of reoccurrence and the fact that getting them up quickly, getting them mobilised quickly, the psychological impact of that is quite powerful. That's
right. So the recontact rate for those service users, patients which access the full service is very, very low. The 2 and 3 day recontact rate is very low. So success all round.
Yeah, fantastic. But Emma, it's great that services are commissioned, particularly I think where they're empowering that kind of response. But NHSE have just launched the Volunteer Task Force report in the last few days, and there's a real call to action about embracing the role of the voluntary sector and embracing volunteers. What are you seeing in terms of the voluntary sector's response to issues like this?
There definitely is, and the Volunteer Task Force report that was published last week was really designed to say, actually, we could do so much more. We know that during the pandemic, that thousands upon thousands of people stepped forward, both in formal volunteering roles, but also in that community response as well. And we wouldn't be where we are without volunteers. Every day, volunteers are helping our patients in communities in so many different ways, right through from very informal volunteering. So millions of us help our neighbours, we help our friends to do things that they might not be otherwise able to do, right the way through to formal volunteering opportunities. And in the ambulance service, we have about 10,000 community first responders who go out and are often, because they're based in their communities, they can just get there faster because they happen to be on somebody's doorstep and they can step in and help. So it's never taking away from the role of paid staff at all. They just happen to be nearer. And in those vital minutes or hours, in the case of falls, before the ambulance can arrive, actually they can do so much. But there's so much more that we could do in relation to the wider community. And the voluntary sector is already doing a phenomenal amount in terms of falls prevention. And actually working with groups of people who are at risk of falling to try and strengthen their mobility and give them confidence, and to do things like checking people's homes to make sure that fall hazards are removed. But it's all about equipping people with the skills and confidence. And actually, if we can equip more people with the skills and confidence to act in the community in the same way we saw during the pandemic, where thousands of people just came forward to help, if we can give those people the skills and confidence to do more around people who may have fallen, actually the impact could be truly phenomenal.
I think that's one of the most powerful points in this whole topic area. I think we're all familiar with commission services, but this idea that we can augment the system with the community. And if you think about cardiac arrest, we're now all used to augmenting the system with the community. We are used to seeing a defib on the wall. We're used to people being trained in CPR and how to use a defib. But to my knowledge, there are no communities where there's a community lifting cushion and people who have undertaken the training to be able to respond. Caroline, from your perspective, looking at, we've got integrated care systems now, in many cases, frailty is their number one priority. Falls within that is a really big part of that. Yep. They've got finite budgets. This idea of equipping the community, augmenting the system with the community, does that fit with how you're seeing the way the systems could work?
Potentially, yeah, absolutely. But I don't think that's where we are right now, are we? I mean, it seems to me that, the initiative that NHS England's taken, Amanda Pritchard has personally really got behind the idea of a more community-based response to falls. But at the moment, I think in lots of places, that's not really happening. It's happening rhetorically, but what we're more seeing is perhaps a falls car being commissioned with the local authority, without all the other extras that I think the voluntary sector could potentially bring, particularly in terms of looking at what else that older person might need to make them feel safe and well and enabled to sustain their independence at home for as long as possible. Of course, a whole set of other issues arise, I think, for older people in care homes, but I expect we're going to come on to that. Yeah,
well, exactly that. I just whilst you're on that subject, I'm wondering about the role of the family. So, I mean, what do families tell you about or tell Age UK about their experience around people falling and their confidence about responding? Because it strikes me that most families feel pretty paralysed when it happens.
Yeah, I think that's a good way of putting it. I think there's a sort of a widely held view, isn't there, that if somebody falls over, all these different words we use, but when someone has a fall or falls as an older person, then you mustn't touch them because if you do, you might do further damage. So that's a kind of widely held belief by the public, and that does tend to mean that perhaps people might seek to make someone comfortable, but be very worried about doing much more than that unless they've had some sort of previous experience. And then, of course, people just worry about how long it might be that somebody is waiting to be, properly picked up, as it were. Those are the kinds of things we mostly hear, I think, from families.
Yeah, and I think our experience as the largest training provider of first aid in the country is that actually only 20% of it's curriculum. You can teach people the first aid skills, 80% of it is confidence. And actually one of the reasons that we haven't gone digital in our first aid training and we keep on bringing people in is because they need the kinesthetic value of practicing something. And I think that if we took the same approach to falls as we do to the rest of first aid, and we said, actually, this is about training people, this is about equipping people. We've always said that equipment is an important part of first aid, whether historically that's the triangular bandage, which a good old first aider still carries around with them, or whether it's an AED or indeed an automatic lifting cushion. And I think this concept of educating and being systematic about educating could make a massive difference. Jason, from your perspective, and I recognise the challenges for care homes, but there's also research that indicates that for many care homes, they are not lifting, and even if they've got a lifting cushion, they're not responding. And it just strikes me that sounds to me like a lack of education, that a lack of equipping the mind and the mindset, and not just the equipment.
I'm glad you asked me about that. I thought you were going to ask me to demonstrate a broad-fold triangular bandage. I'm getting worried. So yes, and certainly from an ambulance perspective, ambulance service perspective, what we do see is a number of care homes who have adopted kind of no lifting policies, so automatically call an emergency ambulance when someone falls. Now the approach we've taken in Wales as part of the fallers framework that we've had, that now includes frailty since last year, is to equip and train about 2/3 of the care homes in Wales with lifting aids. So we've government funded lifting aids, and we've supported the training of staff in those facilities. That's clearly helped us with a reduction in calls and responses to those facilities. And of course, again, it gets the patient, the faller, a much better targeted response. So the approach we've taken is, I guess, Martin, with high volume locations, is to deploy equipment and train people to recognise, assess and use that equipment safely to get the faller up.
And I guess, one of the challenges St John had in the early years of trying to persuade people that CPR could safely be done by civilians, that AEDs could be safely used by civilians, it was that people were really worried about the clinical outcomes. And, of course, in the old days where a defib was, big metal paddles and things, you get it. But automatic defibrillators brought things on. I can imagine some people will have clinical concerns about intervening and say, actually from a clinical perspective, are you getting better outcomes clinically? So, okay, it's all very well reducing wait times, but fundamentally we want older people to be well and to have their well-being improved. Is there any clinical evidence that this is helpful to train people, equip people, get them off the floor?
Well, I mean, I think the first thing to say is that we've got thousands of volunteers, as Emma has touched on, thousands of volunteers across the sector already responding to a range of emergencies, not just fallers. And our community first responders in Wales respond to fallers, have done for many years, and provide great service to those patients. On I guess the avoidance of harm, Martin, we all know, don't we, that a long lier on the floor, will have some degree of harm occur, be that tissue damage or other issues, dependent on where they've fallen and how they are and the length of time. And of course, if those patients are then conveyed to an emergency department, we've got other issues which emerge. They're likely to be admitted, they're likely to end up in a bed, and then we've got the issues of discharge back into the community, which we all know about. So if we can avoid that deterioration at scene by a quicker targeted response, because the emergency ambulance service simply is not going to be able to respond in a timely fashion to those types of calls given the pressures across the system, then we should do everything we can to do that. And if equipping communities is a mechanism to achieve that, Martin, we should do that. And it's entirely possible for people in our communities to do it because they're doing it already.
Yeah.
You know,
Martin,
it's
can I
happening
just
already.
come back in on the care homes issue? Because
Yeah.
I think that's a really interesting one. I think another factor which sometimes comes into play is the whole issue of insurance.
Yep.
And one of the things we discovered during the pandemic was that how beholden many care homes are to very risk-averse insurers. And they bear that risk themselves. They, you know, particularly they're almost all private businesses now. Obviously, there's the big chains, but there's also, as many people will know, lots of smaller care homes who are really quite small businesses. And basically, if your insurer tells you that you've got to wait for the ambulance, then what can you do? And no one stands behind those businesses. NHS England doesn't. It could, for example, could have done during the pandemic. The government could have during the pandemic, but chose not to. So I think that's one issue. Another issue is the rapid churn of staff within care homes and the acute understaffing. So the problem is, of course, you can train people, but you're going to have to keep repeating it.
Yeah.
And then I think the third one is the really big churn and the great lack of registered managers in care homes, who would be typically the people who will set the culture, give people confidence that it's okay to intervene. So I'm not saying we can't do it. Of course we can do it, but it's quite challenging, I think.
It's one of the reasons why, you know, I think the concept of getting into the public psyche that falling is a community health emergency, and drawing the public into this debate, because I think pressure on policymakers is important. You know, if we want a policy framework that's going to help with this, if we want the right political support to make this work, then I think they need to know that the public are alert to this. And you know, it's very difficult to meet somebody that hasn't got a story of an older relative who's fallen. I think we need to harness that energy and bring the public with us on this journey. So it can't be about just care homes or just ambulance services or just community first responders. Yeah. It has to be a public response, a community response, getting the public engaged with this concept of a community health emergency. Emma, you know, integrated care boards, you know, a state of reality, and yet many of them are struggling to get that commissioning process going and off the blocks. What does the task force say about the role of volunteering and volunteer organisations in ICBs, and you know, what can ICBs do to involve the community, augment their system response?
So pretty much the task force recommends that ICBs should involve volunteers more in everything that they do. Practically, what that means is well, volunteers every day improve patient experience and outcomes, and we've talked about the impact that this could have if we were to implement a community falls response on outcomes for people. Volunteers also improve staff experience and well-being, and make a big difference there and reduce pressure on staff. And also, quite often it's a route through to careers, and we know we've got workforce shortages. So the rationale to invest in volunteering is really strong. And so the task force looks at how systems can really harness what's already there, because a lot of these things are already there and people stand ready to respond, and to really invest in it, because volunteering isn't something that's free. You can't just say, right, we need to bring all these people forward and not give them any training and not give them the skills or any supervision. So it really looks at how ICBs can do that. I think I would just add, you were talking about clinical risk before, and it is something that we come across all the time. Whenever we're talking about volunteering, there's a impression that volunteers somehow are less professional than paid members of staff, or that the voluntary sector is less professional. And actually, we see nothing could be further from the truth. The people who do this are people who want to be there, and they really want to help, and they want to gain the skills to make sure that they can help in the right way. And as long as we're giving people that level of confidence and skills and supervision critically, then actually there's no reason why they can't help in these different ways. But we also have lots of things that are available to us that we didn't have when you were talking about the introduction of AEDs in relation to things like video technology. And so it is possible to actually provide somebody with some clinical supervision remotely and actually have a volunteer on scene. And a lot of the community first responders are now doing that, where they're actually on scene with a patient and they phone through to a control room where a qualified clinician will say, actually, yeah, I don't think we need an ambulance now. This is what we can do. Yeah. And they're essentially the eyes and ears on the ground. And so I think there's lots of different things that we can do, and hopefully the task force will help us to get to that place.
Yeah. Jason, I mean, that's pretty much the model you use, isn't it?
It is. So as has been described, you know, our community first responders will go to scene, and whilst they're waiting for the response, the ambulance response, because they're in addition to, not instead of, always in addition to, not instead of, that there is an option for them to seek clinical support either by phone or using video technology, as has been described, from a clinical support desk. That's a model that will operate in most services across the UK too. And of course, there are other areas where we're looking at deploying volunteers. We've professional volunteers, I have to say, Martin,
yeah.
to the point that Emma makes. You know, our volunteers today are professionals in what they're doing.
Yeah.
There are other areas where we're looking to deploy volunteers too, to deal with other issues that we see in our activity. So it is definitely possible, and that clinical support, that clinical decision making, is now available, you know, remotely to support volunteers, professional volunteers on the ground.
Brilliant. Last words from each of you. If we were to describe this as a community health emergency, what would you want to say to your stakeholders about falls? Jason?
Well, I think we have to look, if we look out over the next 10 and 20 and 30 years, what's coming down the track. So we know we've got an ageing population. We know that falls and frailty is going to become more prevalent, certainly in my sector, you know, in the emergency ambulance sector. We have to, therefore, look at a different way at responding to this activity. I think there is absolute merit in engaging communities, particularly in rural and remote areas of the country, in how they can support fallers, people with frailty, in their communities, and ensure that those patients have better access to services. So there is definitely, I think, a call to arms, Martin, if you like, for communities to come forward and get involved, because we can train them, we can equip them, and we can offer that supervision when it's necessary.
Brilliant, thank you. Emma?
I would say have a look at what's already out there. So I agree there's probably no area of the country that has a lifting cushion in the community that people can access, and it would be great to see that. But there is also a load of really good practice going on in pockets across the country. And so I would definitely encourage people to have a look at what's already out there and see what you can learn from others. And if you're not sure where to start, come and speak to me and I'll point you in the right direction.
And you'll be on the NHSE stand?
Yes.
Fantastic. Caroline?
Yeah, I travel optimistically in this area. I think we've got a great opportunity now to do a lot better job, which will really support older people in living better, longer lives, and will also save the NHS quite a lot of money. And I do think over the next few years, technology will be transformational in this space. One of the things I do is I've been judging the NHS Parliamentary Awards recently, and I don't know who's going to win, but actually there was a really great nomination from an area, I can't even remember where it was, which is now equipping its remotely based paid staff with VR technology so that they can actually in real time get expert advice from the centre. Think what a difference that could make in this area. And so I do think we're going to do a lot better job over the next few years, and let's not leave out the voluntary sector. We can really help.
Yeah, I love your optimism, and I do think that's the message I hope that you can take away from today, that whether it's augmenting with the community or augmented reality, there are solutions that are within our grasp. I think if we unite around this idea of falls being a community health emergency, if we embrace the partnership that is much wider than just the healthcare system, I think we can make a difference. We would love to talk to you over on our stand in the exhibition hall, and really, to hear your ideas. I think this is a learning process. We haven't got an instant solution. I think this is a conversation that we're hoping to start here today. I hope you've enjoyed hearing the start of the conversation between us. I hope you will continue that conversation both with us on the stand and back in your communities. Thank you very much for coming.
Thank you.